All right, good afternoon, everyone. While we're filtering in, I want to welcome you all to Medicine Grand Rounds. My name is Vineet Chopra. I'm the chairman of the Department of Medicine. It's nice to see many of you here. I want to welcome Dr. Jennifer Christie, who's sitting in the audience. Dr. Christie is our new chief of GI and hepatology, and this is her first week here, and great to see her at Grand Rounds. Welcome, Dr. Christie. I have a few slides today. So first, scan for your mock credit, your CME credit, if you haven't already. The first few slides, the first is an important announcement. We will not be here next week, so please don't come here next week. We're moving to the Schroeffel Conference Center on the main hospital. And we're doing that for a couple of reasons. The first is we want to make it easier for people to attend Grand Rounds. And we recognize many of you are in the hospital on clinical rotations. And this is not that far, but far enough that it becomes more difficult to attend. So I'm looking at all the trainees and the residents and the students and the faculty in the room. The excuse of I'm on service is no longer an excuse. I want to see you all there. The Schroeffel is bigger, and therefore, if it's not enough people, it looks more empty, and I don't like empty rooms. So please try to be there, especially for those of you online. We really want to see the room packed with many of you. So next week we'll be at Schroeffel, and I'll see you all there. I want to highlight a few of our upcoming Grand Round speakers. On 27th of September, Dr. Josh Barakas, one of our own, will be here talking about public health and some of his work in that space, specifically thinking about how his research and the research of others has informed public health policies. Some of you may know Dr. Barakas. He had a most excellent paper published in JAMA looking at our current housing policies and how those affected Denver. And I think he'll be talking about that among many other things as well. So please be there on 27th. And on the 4th of October, I'm very excited to have Dr. Tayson Bell here. Dr. Bell is board certified in both pulmonary and critical care medicine and infectious diseases. He is a world leader and expert on thinking about information and disinformation, and specifically on the pandemic. So his talk is really going to be exciting because he's going to share lessons he's learned, but also things that we should think about as we communicate about healthcare and health policy delivery. So please join us on the 4th of October as well. Plug here for the Mentorship Academy. For those of you who don't know what this is a one-day event that we are hosting here at CU. This is sponsored by us, the Department of Medicine, and by the Michigan Medicine Department of Surgery. This is something I ran and led when I was at Michigan, and we're very excited to bring it here. It is for all of you. We have tracks for students and residents. We have track for faculty and staff, and we have tracks for mentees and mentors. So if you're a T32 member, if you're looking at your K award, if you're thinking about how do I become a clinician educator, there's value here for all of you. General admission for this is free. We are hosting this through sponsorship, and you can see all of our sponsors there for a number of departments on campus. And it'll open September 25th. I will tell you, we've really gotten a very strong response here, so there won't be a lot of slots left. So when it does open up, please do sign up. I guarantee you, this will be a day worth attending. So look forward to seeing many of you there. That again is October 27th, but registration opens September 25th. And then last but not least, some of you hopefully have seen this, our annual report for the Department of Medicine is now available. This was indeed a labor of love. It's almost 150 pages long. It features all of our leaders, all of our divisions, many of our programs, many of our trainees, as well as many of our affiliates across the entire department. It is a remarkable reminder of all of the great things that our people do here every day. If you haven't seen it yet, please do download it on that PDF. And if you want a hard copy, they're available at the Department of Medicine on AOB 8. So stop by and pick one up. This really is a nice thing to have and should hopefully make you proud of being a member of this incredible department. Okay, so with that background, I'm pleased to actually now introduce our speaker, Dr. Josephine Chou. Dr. Chou is an assistant professor in the Division of Cardiology in the Department of Medicine. She earned her bachelor's in biochemistry and cell biology from UCSF, a master's in physiology and biophysics from Georgetown, and then went on to medical school at Temple University. She then trained at the University Hospitals in Case Western at Cleveland for residency and went on to complete a cardiology fellowship at the University of Pittsburgh Medical Center. From 2015 to 2017, she was a clinical instructor at Bay State Medical Center in Massachusetts, from where she was recruited to Yale University, where she had several leadership roles including serving as the Associate Program Director and then Program Director for the Advanced Heart Failure Fellowship and Director of the Cardio-Obstetrics Program. Dr. Chou and I were talking. We were fortunate to recruit her to Colorado in 2022. She assures me she's not going anywhere given the cost of her house and how much she had to spend to be here. She's currently an assistant professor and serves as the director of our cardio-obstetrics program here at CU. Dr. Chou is funded through several grants, including through those from our Ludeman Center, through an early career faculty research development award, and much of her research interests focus on cardiovascular health of pregnant women. She's published 16 peer-reviewed articles, has authored several book chapters and editorials. She's also the recipient of several awards, including the Resident Research Awards at Case, the Clinician Educator Scholarship Faculty Award at Yale, and most recently, she was selected by the ACC to be a participant in the Clinical Trials Research Cohort, which is an honor reserved for very few people across the country. We're delighted to have her here today to tell us about the Cardio-Obstetrics program at CU. Welcome, Dr. Chou.
All right. Thank you so much, Dr. Chopra, for that very kind introduction, and I'm honored to be here in front of you today, and also to, I guess, be the swan song for Grand Rounds at Krugman. So, what I'd like to do here, because this is a new program, I wanted to illustrate the importance of this program and also what we've accomplished together in this last year or so. So these are my disclosures. And so we'll start with a case with patient BC. She's a 30-year-old Black female. She's coming to us pregnant at 15 weeks gestation. She's admitted for a hypertensive emergency with a blood pressure of 198/125 and symptomatic with a headache and blurry vision. Her past medical history is that this is her second pregnancy. Her last pregnancy was preterm C-section at 32 weeks, and this was complicated by eclampsia. And this occurred less than a year ago, so this is a short interval pregnancy for her. Subsequent to this pregnancy, she was diagnosed with chronic hypertension and maintained on labetalol and allopurinol with okay blood pressure control in the 140s/90s according to her, but once she became pregnant, she stopped the ACE inhibitor, which led to this current decompensation. A secondary hypertension evaluation during that interval period was also unremarkable. Social history and family history are not particularly revealing as of this time. And on her exam, she has afebrile, her heart rate is 90, her blood pressure on recheck is still elevated at 195/110, and she has 95% on room air. On exam, she's euvolemic appearing with a JVP of 7 centimeters. She has regular rate and rhythm, but with a soft early systolic murmur at the upper sternal borders. Her lungs are clear, her abdomen is mildly gravid, and she has no edema. Her labs are not particularly remarkable either, with normal creatinine, normal LFTs, and no protein in her urine. Her current medications are labetalol 200 3 times a day and a baby aspirin. Her EKG shows sinus rhythm with electrical evidence of LVH, and her echo shows normal LV function and confirms that LVH that we see on her EKG. RV function is normal and valves are normal as well, suggesting that murmur that we hear is related to flow and no valvular heart disease. So her subsequent course, she is admitted. Her labetalol is up titrated with a target blood pressure of 140/90. Her symptoms are resolved and she is thus discharged. She's unfortunately has 2 subsequent readmissions for hypertension and eventually is on max doses of labetalol and hydralazine. She was tried on nifedipine when this was stopped because of tachycardia. She established with cardio-obstetrics and maternal fetal medicine for subsequent med titrations and delivery planning. And the plan for delivery was at 37 weeks, which is in keeping with our guidelines for those with chronic hypertension. And she desired to have a repeat C-section because of her initial one from before. We had our doubts she would make it to 37 weeks. And lo and behold, she was admitted at 29 weeks with severe range blood pressures and a new headache. At this point, she was diagnosed with superimposed preeclampsia with severe features. Blood pressures and her symptoms were refractory to escalating doses of IV hydralazine and labetalol, and so she underwent an emergent C-section on the day of admission with the delivery of a baby girl who went to the NICU promptly. Blood pressures did creep up after delivery to 150/90, so enalapril was added to her regimen, and she was maintained on her hydralazine and labetalol. She chose to breastfeed, and hence the regimen that you see there. And so her questions to me at this point are, what does this mean for my health long term? Can I get off, if I can just get off my medicines, will I be okay? Which is a common question I hear from young patients. And could my preeclampsia have been prevented with this second round? So hypertensive disorders of pregnancy, this is the most common cardiovascular complication in the United States, with Black patients shouldering the majority, higher burden of incidence, related morbidity, and mortality. Risk factors as listed are as such, including increased maternal age, obesity, multifetal gestation, chronic hypertension, and history of hypertensive disorder of pregnancy, which is what our patient carried. The definition broadly is new onset hypertension at 20 weeks gestation or beyond, and there is a wide spectrum of disease, starting at gestational hypertension with just an elevation in blood pressure, preeclampsia with that elevation in blood pressure and evidence of end organ dysfunction, and preeclampsia with severe features, which is severe range blood pressures and severe end organ dysfunction. Eclampsia, which is preeclampsia with seizures, and HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets, fall within the severe preeclampsia spectrum. Chronic hypertension with superimposed preeclampsia is a little bit trickier to diagnose, but is defined as hypertension before 20 weeks gestation. So it can precede pregnancy or develop within those initial weeks, and then a worsening of those blood pressures or symptoms after 20 weeks gestation, which is why our patient only carried that diagnosis at her final admission. The theory of etiology is that it starts with abnormal placentation, where these uterine spiral arteries develop abnormally and they're narrow and resistant and don't give adequate blood flow to the placenta. And this results in placental malperfusion, which then releases this anti-angiogenic imbalance into the systemic circulation. SFLT is a pro-angiogenic protein that's released by the placenta, and SFLT is anti-angiogenic, and there's an imbalance of this when the placenta is malperfused. And so you get this systemic sort of endothelial dysfunction and inflammatory imbalance with this feeds back into the placenta, further inhibiting artery formation and furthering placental hypoxia, which then creates the cycle that persists throughout pregnancy. Because those values are more abnormal in severe cases of preeclampsia and eclampsia, and as a result, the clinical manifestations of these diseases, of the severe form disease, is worse as well, with higher rates of end organ dysfunction, such as acute renal failure, pulmonary edema, need for mechanical ventilation, and obviously much higher rates of maternal mortality, as you see in that bottom line there. While our patient survived her pregnancy, not all patients are as fortunate, and this is unfortunately in the news very recently. You may have read about this with Ms. Tori Bowie, who is an Olympic athlete who was 8 months pregnant when she passed away at home during labor and thought to die of complications of eclampsia and subsequent respiratory distress. So tragic enough when there's one maternal death, and unfortunately this is part of an increasing trend in the United States where our rates of pregnancy-related mortality are increasing. This starts from 1987 and increases through 2013, but more recent data is not any better. This is through 2020, where those rates of maternal mortality continue to rise. And again, there's a disproportionate burden borne by our African-American population with higher rates of mortality within this group. Cardiovascular disease is the leading cause of pregnancy-related death in our country, with cardiomyopathy and hypertensive disorders rounding out the top 10. But I do want to remind us that while we focus on mortality, because that's the easiest number to measure, this is only the tip of the iceberg when we talk about related morbidity. This is data from California from 2007, but remains relevant today. But in that year, they had 8 related preeclampsia-related mortality, but then 40 to 50% that of patients who almost died during that hospital stay, requiring an ICU admission, another 400 to 500 those who suffered a serious morbidity, such as prolonged hospital stay or readmission or ER visits. And if we're to expand this circle out to include long-term cardiovascular effects of preeclampsia, you would imagine that circle is even bigger. Why is this happening? 2 reasons. One is that the pregnancy imposes a significant cardiovascular strain, a strain on the cardiovascular system. So systemic vascular resistance drops within the first trimester in this sort of cyan blue line that you see at the bottom here. Cardiac output subsequently rises to peak at about 15 to 30% beyond that of pre-pregnancy values, and plasma volume follows to try and expand to fill that vascular space. And as a result, cardiac output increases by 30 to 50% that of pre-pregnancy values. These values plateau and are maintained throughout the majority of the pregnancy in the 2nd and 3rd trimesters. There's further augmentation of these changes during labor and delivery, particularly for a vaginal delivery, and then rapid normalization within the first 2 weeks postpartum. So easily we can, there's unmasking of prior cardiac disease and also occurrence of de novo cardiac disease, both of which our patient experienced between her 1st and 2nd pregnancies. The second reason is that women are coming into pregnancy at an older age, and as a result carry more cardiovascular risk factors with them. Chronic diabetes and chronic hypertension are more common as women are older, and this increases their risk of gestational hypertension and gestational diabetes, and that further increases the risk of these chronic conditions postpartum, which, if not well controlled, further increases the risk of complications in subsequent pregnancies. And so as a result of these trends, the CDC has made an effort to try and understand why these are occurring, and they instituted the Maternal Mortality Review Information Act, which published its first set of data in 2017, which looked at the preventability of pregnancy-related deaths. And when they looked at the individual factors with each of these deaths, they found that about 60% of these deaths may have been preventable through a reasonable change to one of those factors, which we'll go into in a minute. They reanalyzed this data in 2020, and the numbers are not much better, with about 84% of these deaths now being preventable with one of these factors. So the critical factors they identified can be broken down into patient, provider, and systems of care factors. And from the patient end, they identified chronic medical conditions that were either underdiagnosed or undertreated during that interval time period before the pregnancy or afterwards. And then a lack of knowledge from the patient perspective of not knowing when to seek care, when symptoms started to appear and complications started to arise. From a provider's perspective, there was a misdiagnosis that resulted in delay of diagnosis and effective treatment, most commonly seen when there was coronary disease involved, failure to seek expert consultation, which was most commonly involved when there was cardiomyopathy or heart failure, and then the use of ineffective treatments, which is what we saw typically in hypertensive disorders of pregnancy. And then lastly, from a systems of care perspective, the overarching theme was a breakdown in communication between providers and a lack of care coordination. So either people didn't know who to call or weren't able to reach them in a timely manner, and this resulted in an adverse outcome for the patient. And none of this is meant to be punitive or to say that we're doing a poor job. It just illustrates these very wide gaps that we have in our current systems of care that fail us when it comes to trying to care for patients who have pregnancy and heart disease. And so that's where Cardio-Obstetrics comes in, and we try to bridge this gap with what we saw prior. And we do this through a combination of clinical care, research, and education. And I'd like to spend the next 20 minutes or so is to highlight what we're doing here at CU, what we've done in the past year, and where we're moving forward in each one of these sections. So for clinical care, this was formally established in August of 2022 when I joined faculty here. We provide pregnancy-related care for patients with cardiovascular disease. The primary site is here at Anschutz, but because of patient volume, we're actually expanding up to Northern Colorado and starting an outreach clinic at Poudre Valley next week. Most of our patients are de novo to us, but for those who are already established, we do offer co-management or temporary transfer of care in an effort to facilitate communication. Our clinic volumes have grown steadily, as you can see at this bar graph down here, with a steady influx of new patients. And because each new patient gets to at least 2 or 3 visits, there's an increasing number of return visits. March, I was on service and it's strep throat, and hence there's that blip there, but overall an increased trajectory upwards. Volumes wise, I'm average about 15 to 20 active pregnant patients at any given time, and we're up to about 70 postpartum patients at this point. The diagnoses that we see in this clinic are diverse, as you can see here, ranging from arrhythmia, cardiomyopathy, aortic disease, coronary disease, and valvular heart disease. So the majority of our patients still have hypertensive disorders of pregnancy, and we're probably not even capturing all of them because of our one location here. We focus on clinical care both during pregnancy and afterwards. For antenatal management, it's reducing the risk of cardiac complications during pregnancy and also planning for delivery. This is achieved through a multidisciplinary team, which at the core is maternal fetal medicine, OB anesthesia, adult congenital heart disease, and OB and cardio-OB, but we do involve other subspecialties depending on the disease state that the patient has. Each patient gets an individual care plan, and this includes timing and mode of delivery. Vaginal delivery is safe for the majority of our patients, but for some, C-section is preferred from a cardiac perspective, indicated from an obstetrical perspective, or that's just what the patient wants. Medications, we review delivery anesthesia and also what uterotonics to avoid, depending on the side effects from the cardiovascular perspective, and how to manage anticoagulation and hypertensives, both in the antepartum period and in the postpartum period. Delivery location is the most common question we get asked because Anschutz is the only center in Colorado that offers maternal telemetry. So for patients who require that, it is strongly recommended that they deliver here. If they're from a distance, then they're asked to temporarily relocate around the time of delivery, so they're not delivering on the side of the highway, which is usually not great for us. Inpatient, and then we also review plans for postpartum patient monitoring, whether patients need the CCU and need closer monitoring, or whether they can recover on mom and baby. Most importantly, these plans are communicated to the patients so they understand why this is happening, and any changes are communicated with them as well so they're up to date and know what to expect. And as we've encountered more, some of our common conditions or situations, we're working on developing institutional protocols so that we streamline our workflow. Inpatient care is provided through the cardiology consult service and our fellows, and I'm very grateful for them for taking on these patients, and then staffed with me or the attending on call. And then patients are transferred to the CCU on an as-needed basis. If they are decompensating, we've delivered a couple patients in the CCU as well, so that is capable. The exception, not the norm, to say the least. Postpartum, though, I do want to focus on this aspect again, because particularly when patients come out of pregnancy with a cardiac condition, there's a lot for them to navigate in addition to all the struggles and challenges of having a newborn. And first and foremost, the frequency of care in and of itself is a challenge for them, because the frequency of care during pregnancy is so much more than that after pregnancy. And when patients are trying to navigate a new diagnosis and a new child, even just this drop in frequency of care can be overwhelming for them, and they need resources and they need support during this difficult time. So for our postpartum care, we do try and provide that clinical support to the best that we can. For patients who are at high risk of decompensating, we offer clinic visits at 1, 3, 6, and 12 months. And for all others, at least a visit within the 3 to 6 month period. We do symptom checks here to try and catch decompensation early, cardiovascular risk assessment within that initial postpartum period, and also counseling regarding long-term management. And this all needs to be taken into account, that patients need to be ready to start these steps, and that's variable with each patient depending on what else they're going through. So the frequency of visits is meant to try and give them an opportunity to come and start that when they're ready. We're also initiating a postpartum hypertension clinic, which is a nurse-driven antihypertensive medication titration protocol in order to streamline this procedure. And then lastly, rounding out the reproductive cycle with preconception counseling and contraception for patients who are considering another pregnancy. We'll want to optimize their risk factors and reduce their risk for complications with a subsequent pregnancy. And for those who are done with family building, to ensure they have a proper referral for birth control, so that that's in line with what their goals are. And in particular, this postpartum management is key for those who have experienced a hypertensive disorder of pregnancy. What we were taught, maybe a lot of us in medical school, is that preeclampsia was cured by delivery, and we're finding that is very much so not the case. These placental abnormalities that we illustrated before that lead to adverse pregnancy outcomes lead to subclinical cardiac disease with abnormal cardiac mechanics, coronary endothelial dysfunction, and loss of arterial compliance that then manifests as overt cardiovascular disease as soon as the early postpartum period, but persists throughout the lifespan of the patient. So pregnancy can be really thought of as a stress test for the cardiovascular system, where those who are healthy and without many risk factors have this sort of undulating symptomatology that remains subclinical. But for those who have a complication such as preeclampsia, their threshold for cardiovascular disease is crested during pregnancy, but also doesn't return to normal during the postpartum state, and increases their risk of subsequent complications in pregnancy and also premature cardiovascular disease lifelong. So this is nicely illustrated by chronic hypertension, which is our biggest risk factor for lifelong cardiovascular disease, that patients who have a hypertensive disorder of pregnancy have a 6 times higher likelihood of being diagnosed with chronic hypertension within the first 2 years. And this risk is highest within the first 6 months. So this seems to be a window of opportunity for us to catch and diagnose this condition, but we're frequently missing this. This was a survey that was done where they looked at patients with chronic hypertension and a hypertensive disorder of pregnancy 10 years after the fact. And at the time of this trial, despite all of them meeting criteria for chronic hypertension, only 40% of them carried the diagnosis formally. And the other 60% probably would have been missed had they not happened to enroll in this particular trial. Within that first year, there's also higher rates of other cardiovascular risk factors, such as impaired fasting glucose, dyslipidemia, and metabolic syndrome, all of which are more effectively treated early on rather than later. Chronic hypertension also, the risk of it increases with cardiovascular risk modifiers. So this was a survey that looked at some of these risk modifiers and this is a graph showing the effect of obesity on the history of background of hypertensive disorder, pregnancy, and the highest risk of chronic hypertension are patients who carried both of these risk factors, higher than those with just one of these risk factors, as in these lines below, and this lowest line is patients without either of those risk factors. But when you stratified by age, patients who were 39 years or younger had nearly a double-fold hazard ratio as compared to those who were younger, suggesting that when we start this risk modification earlier, we have a greater risk reduction over the lifespan of these patients. And similar trends were seen with diet, exercise, and tobacco use, again illustrating the importance of using those initial years as a window for us to initiate care. And that particularly when we look at the lifelong rates of cardiovascular disease in patients with HDP, this becomes even more important. So they, over their lifespan, they're at a nearly twofold higher increased risk of coronary artery disease and heart failure, and nearly a three to fivefold higher increased risk of valvular heart disease. And these graphs down at the bottom, these survival graphs, no HDP in the blue and HDP in the red, not only are their hazard ratios higher, but these curves are shifted over to the left. So they're getting disease earlier in addition to being at higher risk for that. So this goes to show that we really need to be using these pregnancy-related complications as the equivalent of cardiovascular risk factors, not only for preventing complications in future pregnancies, but for using it as a sentinel event for us to be aggressive at modifying other cardiovascular risk factors that may not necessarily be developing at the time we're seeing the patient, but they are certainly at higher risk for. So that includes being aggressive with screening for diabetes, hypertension, dyslipidemia, and being aggressive about smoking cessation, weight loss, and physical inactivity. And so this initial postpartum year, truly a window of opportunity that we can modify somebody's lifelong cardiovascular health, where this is a time that we can evaluate signs and symptoms early so we can catch complications and then promptly diagnose and treat pregnancy-related conditions as to not let them balloon up into something more serious later on. And then furthermore, this gives us an opportunity to engage our patients early in lifelong cardiovascular risk modification by screening their family history, doing blood pressure checks, screening for diabetes and dyslipidemia, and focusing on smoking cessation, exercise, and weight loss. And we all know from treating patients, this is not something you can accomplish in 1 or 2 visits. This requires a long-term relationship with these patients to implement significant change in these areas. So our hope would be that we're able to change this trajectory to something that looks more like this through targeted screening, lifestyle modification, and early treatment. Cardio-OB clinic is only one of many, and in order to achieve this on a much larger scale, we need the involvement of our respective subspecialties in internal medicine, obstetrics, and also the buy-in of our patients so they know why they're doing all this. So this is where education becomes important, the proverbial teaching somebody to fish versus just giving it to them. So I want to start with our patients. What do they know about preeclampsia? They certainly know the term because it's everywhere in the news. And even if it's not in the news, it's in our TV shows. So they certainly know that this term exists and what they read. And I didn't go into social media because I'm not on all that stuff, but I'm sure it's there. So this was a survey that was done of about 800 patients who were diagnosed with preeclampsia, and they retrospectively analyzed what they knew before they're diagnosed and then what they knew afterwards. So before they were diagnosed, the majority of the patients had at least heard of the term preeclampsia, but the minority of them knew what the symptoms were. And because of that gap in knowledge, the majority of them delayed care because of the symptoms they experienced. And in retrospect, the majority of them said had they known about the symptoms, they would have sought care sooner or done something different. But even after their diagnosis, while the majority of them were told that they had to follow up with somebody, they weren't given really much more information beyond that. Only 31% was given any additional information about what this diagnosis meant, what it was. And 30% didn't feel like they were even involved in any of the decision making. So they didn't know why they were taking the medications, going to these follow-ups, taking their time out of their day with their baby to go to all these appointments. And regarding long-term risk, while 63% were told about recurrent preeclampsia and subsequent pregnancies, only 21% were counseled on long-term cardiovascular risk. All those slides I showed you before, only 21% of patients even know about that. So many of these patients think that preeclampsia is done, when they're done delivering, and they don't know anything else, that there needs to be care that goes beyond that. With all this, patients are distressed with this diagnosis. This worries them. And 86% reported at least some or serious mental or emotional impact of this diagnosis to them. And when patients are this distressed about a diagnosis, they will go looking for information. So we've launched here a patient education series, formal education sessions through the Ludeman Center Let's Talk series, which is a fantastic series on women's health in general. And we were fortunate to present a cardiovascular session as part of Heart Health Month in February. But again, those are the exception, not the norm. And so the majority of where we interact with our patients, provide education, remains in clinic visits. And that's what we try to achieve in the cardio-OB visits. And other centers have instituted postpartum transitional clinics, which have been fairly well received. But the majority of patients are still cared for in internal medicine and OB clinics. And here there's a wide variety or a wide heterogeneity as to what knowledge or action is undertaken depending on the subspecialty of the provider seeing these patients. This was a survey where they asked internists and OBGYNs as to cardiovascular risk and hypertensive disorders of pregnancy. And what they found was that OBGYNs were more likely to elicit that obstetrical history and to get that history of a hypertensive disorder of pregnancy, but less likely to order any follow-up studies like impaired fasting sugars, fasting lipids, or any of those screening tests. Internists are less likely to ask that reproductive history, but when they are more likely to order those preventative studies, but still not great, not above 50%. So significant, there's a lot of heterogeneity as to what patients are getting in our clinic visits. And as a result, only about 40% are hearing about preeclampsia and long-term cardiovascular risk from their primary provider. And the remainder are getting this knowledge from self-research. And they may stumble upon some good resources, like what an example here from the California Quality Care Initiative. ACC has some nice resources as well, but it's very hit or miss. And they may only get their information from news stories and social media, but the overarching theme of those is that preeclampsia is dangerous and needs to be treated. And when that message is met with ambivalence or a lack of action in the clinic visits, there's very much a disconnect in this perceived severity of disease. And in our day and age, with distrust in the medical system, that's unfortunately getting worse. What happens is that this erodes the confidence of our patients in the medical community and in our clinics, and that they felt like they weren't being given all the information they needed to manage their disease. It doesn't encourage follow-up, and it doesn't encourage engagement. So we need to improve our providers' education or our providers' knowledge regarding this subject. So where are those knowledge gaps? So this was a survey that was done of cardiology practices, and comfort as to how comfortable they were with caring for a variety of cardio-OB disease conditions. Hypertension is sort of up here. These percentages, the higher the percentage, the less comfortable those people were with caring for this disease condition. So cardiology attendings, about 21% of them, not great with, or didn't feel comfortable with managing hypertension in pregnancy. When you go to fellows, the number increases to nearly 40%. And then the remainder of the cardiovascular team, this includes nurses, pharmacists, nurse practitioners, and physician assistants who arguably have more patient face time than attendings or fellows, are least comfortable at about 60% of them. So just because somebody's uncomfortable with something doesn't necessarily, the question is, do they want to learn more about it, or are they sort of happy with the status quo and referring to somebody else? This was a knowledge survey that I did back at my prior institution, but I believe still holds relevance. So this is, I asked where people had gotten their education thus far as to these various topics, with hypertension being this first one here. And most of education people had received was very informal, sort of on the fly or just sort of on work rounds. And when asked if they wanted to learn more, the overwhelming response was that they wanted more formal education in all of these categories, hypertension not excluded. And the sentiment that I've received here is similar, just on an anecdotal basis. So we're launching several education endeavors, or we have launched several of these. So for our trainees, our cardiology fellows have a Women's Cardiovascular Academic Day, which this past year, Cardio-OB was made up half of the topics. Our internal medicine residents receive a pregnancy and heart disease talk as part of their CCU morning didactics, which includes pregnancy hemodynamics and how to manage cardiac arrest in pregnancy. The MFM fellows will begin to rotate with us in cardiology clinic to help bridge some of those clinical gaps. And then all trainees, as they rotate through our inpatient, outpatient services, and we're a major referral center for patients with these conditions, will receive more exposure on their rounds. For our practicing providers, Grand Rounds is a fantastic place to receive education for conditions we don't see often. So thank you for having me here today. I also had the pleasure of giving cardiology Grand Rounds when I first started. Heart Month in February is a great way for us to increase awareness as well. And we focus on postpartum care through UC Heart Health Month, and then the Children's Hospital Physician Relations Lecture Series. And then lastly, but not least importantly, through clinical outreach with our clinics and through sharing mutual patients, which offers us a direct mode of communication to allow us to communicate and collaborate and learn from each other. And so together, my hope is that we can change the trajectory of disease in this way so that we're reducing the risk of complications for subsequent pregnancies and also lifelong cardiovascular disease. So, but can we do better? Can we, at the onset of that initial sentinel event, can we reduce the morbidity associated with that event through early and effective treatment? And so in the last 10 minutes or so, I'd like to highlight what we're doing in the way of research here. But before that, I do want to launch in some background as to some research that's happened recently internationally that has changed how we manage preeclampsia. So if you remember, our patient was on a baby dose, on a low dose aspirin. And this comes from the thought that aspirin may attenuate vascular inflammation and those antiangiogenic properties that we talked about early on in the development of preeclampsia. The most recent trial that looked at this was the ASPIRE trial. This was published in 2017. Moderate dose aspirin initiated in the second trimester of pregnancy reduced the rate of preterm preeclampsia. There have been several other smaller trials that looked at this as well. So the US Preventive Task Force initiated a meta-analysis of all these trials to evaluate the benefit of preeclampsia or the reduction of preeclampsia-related morbidity and mortality with aspirin use. And what they found is that it did reduce the risk of preterm preeclampsia, as well as reducing the rates of preterm birth, intrauterine growth restriction, and perinatal mortality without an increased risk of bleeding or postpartum hemorrhage. And so as a result of this, the USPTF and also the American College of Obstetrics and Gynecology recommend a low-dose aspirin for prevention of preterm preeclampsia for patients who are at high risk. And that high risk is in this graph over here, of which chronic hypertension fits squarely into the middle right there. The second thing you might recall from our patient is that we targeted a blood pressure of 140/90 during her initial hospital stay. And that new guideline comes from a trial that was published last year called the CHAP trial, which looked at chronic hypertension in pregnancy. And what they did here was that the control group, which was usual standard of care at the time, you target a blood pressure of 160/105, and medications are not titrated or initiated until you reach that threshold. In the trial, the active treatment group targeted a lower blood pressure, less than 140/90, in which they would begin to either titrate or initiate blood pressure medications. The endpoint was a composite endpoint, which looked at preeclampsia with severe features, preterm delivery, placental abruption, and also fetal and neonatal death. And there was a statistically significant reduction in this primary composite endpoint with the active treatment group and targeting a lower blood pressure. So as a result, the American College of Obstetrics and Gynecology now recommends a lower threshold of 140/90 for patients with chronic hypertension in pregnancy, at which we would initiate or titrate medical therapy, as opposed to the previous threshold of 160/110. With composite endpoints, I do think it's always helpful to look at the individual ones. And so these are the maternal outcomes. And I think it's worth noting that even with the active treatment group and targeting that lower blood pressure, 1 in 4 of these patients still went on to develop preeclampsia, and then hypertension you see above there, 1 in 3, and that's even with that lower blood pressure target. So this suggests that blood pressure, targeting blood pressure in and of itself, is insufficient to effectively prevent preeclampsia or reduce the risk of this happening. So can we improve our medical treatment of preeclampsia? And what you might recall as well, thirdly, is that our patient was readmitted 3 times and before we were able to get her blood pressure under some kind of reasonable control. And even then, we weren't able to prevent preterm labor nor preterm preeclampsia. It's worth reviewing that first-line treatments through ACOG have not changed with any of these previous trials I've listed. So right now, first-line therapies remain intravenous labetalol, intravenous hydralazine, and oral nifedipine. But ACOG does stipulate that the current available evidence is inadequate to demonstrate a therapeutic advantage of one drug over another. So our obstetrical colleagues really have no guidance as to which drug to pick, and they're choosing empirically or what they have the best experience with. This would all be well and fine if preeclampsia was one and all the same, but it's not. And particularly from a hemodynamic perspective, this is a heterogeneous condition. So this is so typically with mild preeclampsia, maybe even up to 50% of those who have severe preeclampsia preeclampsia, they have what is similar to that of normal pregnancy, which is this kind of high output and low vascular resistance state. This is a very similar graph to what I showed you earlier on in the talk with the normal hemodynamics in pregnancy, with a rise in cardiac output and a drop in systemic vascular resistance. But what typically happens in severe preeclampsia is you actually have an inversion of those graphs, where systemic vascular resistance rises in the second trimester and continues to climb, and as a result depresses the ability of cardiac output to augment appropriately, and actually has a drop in cardiac output when you approach the third trimester. And when you have this high resistance, low output state, you can imagine giving a medication such as a beta blocker can actually exacerbate these hemodynamic abnormalities by further depressing cardiac output and leaving systemic vascular resistance elevated. So with this data, the question is, can we, using hemodynamics, might give us more effective preeclampsia treatment? And this has been looked at in a couple older studies. This was published in, 1999, where they randomized patients who had preeclampsia and hypertensive emergency to either oral nifedipine or IV labetalol. And both groups did achieve a reduction in their blood pressure, but how they got there was important, where the patients who received nifedipine actually achieved this through a drop in systemic vascular resistance, a drop of 3,500, 2,500. Those with labetalol did not change that resistance by much, and those patients actually achieved a drop in blood pressure primarily through this reduction in cardiac output. And nifedipine, if you notice, as we increase that vascular space, those patients were actually able to augment their cardiac outputs and improve maternal hemodynamics in that regard. So the next question is, can we use hemodynamics to guide our treatment rather than mean arterial pressure? And prior to today, there's been only one study that's looked at this. This was published in 1989, and I apologize for anybody who I've offended by calling the study old. But in this study, they categorized people based on their initial hemodynamics. So patients who had presented with elevated systemic vascular resistance numbers were categorized as high resistance patients and given a vasodilator and hydralazine. And those who had high cardiac outputs were categorized as high output and given atenolol. And as a result of that, both groups did achieve a reduction in blood pressure, but again, how they got there matters, with those who received atenolol achieving that through a reduction in cardiac output, and those who received hydralazine achieving that through a reduction in systemic vascular resistance. The reason this hasn't caught on, though, is as you all know from measuring hemodynamics, the way we do that is we take someone to the cath lab, stick a swan in their neck, and park them in the CCU in bed for a prolonged period of time. And that is a no-go for a variety of reasons in pregnancy, and certainly not so in a condition as common as preeclampsia. But now we have ways of measuring hemodynamics non-invasively and with less of a impact on our patients' mobility. So the ClearSight finger cuff, this is the technology I want to highlight today. This is made by Edwards. It's able to measure hemodynamically through an external finger probe. It's kind of like a mini blood pressure cuff for the finger. And what it does is it generates a set of hemodynamics every 20 seconds. And that set includes cardiac output, systemic vascular resistance, mean arterial pressure, stroke volume, and heart rate. And it will generate that both in an Excel file and also in a graph form, which I will show you in a second. And this entire apparatus fits on the equivalent of a size of about an IV pole. So the footprint is really small at the bedside, and it's also ambulatory. Patients can walk with this and go to the OR with it, and are quite mobile with it as well. This has been validated against invasive hemodynamics and blood pressure monitoring modalities in non-pregnant populations. And at our prior institution, we did validate these values against 3D echo in the preeclampsia with severe features populations in the PEC hemo pilot. This is a picture from that study. That's me with a mask. This is Christina Ackerman, one of our MFM fellows at Yale, who's now an attending at Baylor. And so when they generate numbers, it will generate in a graph form in Excel. It'll also pop up on the screen so you can see how numbers are changing almost in real time. It will also generate out a graph like this so you can visually see how things are changing. And what you'll note, this is one of our earliest patients, but what you'll see is sort of this dip in systemic vascular resistance and this rise in cardiac output here. And what happened here is when we started the study, the patient was supine. She's on her back. And in the third trimester, the uterus compresses the IVC and the aorta, and thus imposes a certain amount of resistance on the peripheral vasculature. And then we did her echo. And what happens with an echo is people roll onto the left lateral side, the uterus is displaced from those great vessels, and you get a drop in systemic vascular resistance. You can actually augment cardiac output and stroke volume with that. So you're seeing it graphically in real time. This is what happened with our patient when she had her echo, that her vascular resistance dropped and her cardiac output augmented. The echo was finished. She rolled back on her back, and then her SVR came back up. Oh, where's my mouse? Right there. SVR came back up. Cardiac output came back down. So you can easily see how we can implement this with, say, if we want to give a medication and we want to see what happens hemodynamically, we can track in virtually real time how this affects maternal hemodynamics and adjust accordingly. So the next steps then, what we're going to be doing here is a study called the PEC Hemo-OBS trial, which is the continuous hemodynamic characterization of preeclampsia with severe features. And what we're trying to achieve with this study is that we want to show that we can rapidly characterize hemodynamic profiles as either high output or high resistance that contribute to uncontrolled blood pressures in patients with preeclampsia and severe features. And based on those initial hemodynamic profiles, we want to determine how cardiac output and systemic vascular resistance change depending on what medication the patients receive, whether it's labetalol, nifedipine, or hydralazine, as given per the usual clinical care. This is an observational trial, so we're not going to be dictating what medications people give are getting. This will be determined by their treating team, and so kind of pseudo-randomized in that regard, with the hypothesis that patients who start with high vascular resistance, for example, if given labetalol, you'll have a worsening of those hemodynamics as opposed to if they were given a beta blocker instead. So the future directions, the hope is that this trial form the basis for future trials that allow us to look at individual hemodynamic profiling in preeclampsia, and that this will allow us to personalize antihypertensive treatments, enable more rapid and effective blood pressure control in preeclampsia, that we can titrate these medications over the course of an hour rather than days. And then ultimately, as we improve maternal hemodynamics, that this attenuates those complications that we know about preeclampsia, and that we can reduce maternal fetal complications associated with preeclampsia. I do want to thank the Ludeman Center for giving us the Early Career Faculty Research Development Award for this, and to thank you to Dr. Regensteiner, her and the committee for enabling us this opportunity, and then to my mentors, Drs. Allen, Hurt, Cornwell, and Wood, as we embark on this journey, hopefully in the next couple of weeks or so. So circle back for our patient update. So she came to her follow-up for blood pressure med titrations, and at her 3-month postpartum visit, her blood pressure was down to 135/95. She remains on labetalol and nalipro. We were able to get her off hydralazine. Likely has persistent chronic hypertension, but we will try to continue to down titrate her medications to prove that this is what she needs. Her postpartum BMI on screening was 30, so in the obese range, and she was home caring for her baby daughter, who at this point had come home, and her 2-year-old son from her prior pregnancy, so she doesn't have a whole lot of time. So she does not exercise, and she just kind of eats whatever she can, which is kind of typical for new motherhood. She has started smoking to help with her weight loss and stress. And on further questioning about her family history, although we initially got something negative, she now remembers that her father had an MI at the age of 45. So family history of premature coronary disease, which is additive to her risk. So when we look at her cardiovascular risk assessment, she has several traditional risk factors, including chronic hypertension, obesity, and now family history. She has several emerging risk factors, such as a hypertensive disorder, pregnancy, and preterm birth weight, and then several factors on lifestyle that are potentially targetable, such as her low physical activity, diet, and then working on smoking cessation. So in answer to her questions, what does this mean for her cardiac health? She does have an increased risk of cardiovascular disease lifelong, starting even now, even early on, but this risk is modifiable if we treat these risk factors above that we've identified, and ongoing clinic follow-up to try to address these on a longitudinal basis is really important. If she can just get off her meds, will she be okay? No, but we'll continue to try to wean. But even if she needs the meds to treat her blood pressure, that is a better way of reducing risk than simply trying to get off medications, and it's also addressing these risk factors below. And could my preeclampsia have been prevented, not with the way our treatment, or not with our current treatment options, but we have research ongoing that gives us hope that maybe we can in the future. So in closing, I do want to thank everyone on this slide who has made this program possible, and for allowing me this fantastic opportunity to be here, and all the people who support everyone listed up here. And then thank you so much. Thank you for your attention, and I'd be happy to take any questions.
Okay, we're gonna find a remote microphone. Questions for Dr. Chou? What's over there? Oh, we have one over here. Dr. Mattinger.
Thank you. It's very interesting.
Thank you.
Do you see or do you anticipate any further perturbations in the cardiac physiology in patients who are living at high altitude?
I'm sorry, do you mind repeating that? I couldn't.
Yeah,
Oh.
the question was, do you see any perturbations in cardiac physiology among patients living at higher altitude, such as here?
Yeah, that's a good question. And anecdotally, their blood pressures are higher, oxygen levels are lower, and there may be an alteration in severity of cardiac disease, particularly hypertension, being seen at altitude. So it's something we account for. We can't adjust for it here, so we treat to the best that we can.
We have a question from the chat from Sonia Flores. She said, wonderful talk. This has been investigated before, but is there more clarity as to what are the etiological factors that result in disparities in outcomes for hypertensive pregnant Black women? Would you speculate as to whether it's genetics, environmental economic factors, lack of access to info, or biases from providers?
That is an excellent question, very complicated. So it's important to remember that race is a social construct. It in and of itself is not a risk factor for disease. It encompasses a variety of things that include ethnicity, genetics, socioeconomics, and a plethora of other things like access to health. So cardio-OB, we try to address the clinical biases that go into that care by using facts and numbers and providing equitable and parity in care. If we want to address maternal mortality and health disparities, though, it requires a lot more than just a cardio-OB program. You need the buy-in of the entire medical system. You need economics. You need social justice. You need social sciences, and a lot of other aspects will need to go into that equation if we're going to impact maternal mortality in that regard.
Dr. Chou, I have a question about your clinic. Tell me a little bit about the mechanics. How does one get referred there? And then maybe also on the consult service on the inpatient side, is it largely MFM that's sort of reaching out, or do you have people that you know are coming in and they're on the radar? Just give me a sense of kind of how you provide the service to patients who might need it.
Yeah, thank you for that. So outpatient-wise, patients are directly referred from us for maternal fetal medicine or OB, and as word of mouth, we're getting more exposure through word of mouth. We're getting patients from other health systems within the Denver area, particularly if they need to deliver in a place that requires maternal telemetry. And so when patients call, the patients can self-refer in as well. We've gotten a number of patients with those, and they call in. They're taken through a decision tree to get to me, but they can also ask for me by name, and that's how they get to my clinic. On the inpatient side, it's usually from maternal fetal medicine and OB, where there's a patient with a cardiac condition, and they call me directly, and then we involve the consult service. If it comes through the consult tree, and then the nurse practitioners, the PAs, and the fellows, hopefully the fellows, I see some back there, so will reach out to me, and we'll staff the patient together. So.
And to be clear, you're an N of one.
I am an N of one. But I do want to thank Dr. Allen, who's been very supportive of this program, and we are more than happy to add to our numbers. We're just looking for the right people.
Can I ask? Is there other questions? Can I ask a question about? You mentioned a little bit about the individual care plans for patients. How does that conversation unfold? I can imagine you would recommend certain things, but it's a lot to ask them to move to Denver, be in the area, be available, pack your bags, that kind of.
Yeah.
So how do you manage that as you're having those conversations with patients?
So we have a monthly care conference with all of the subspecialties that I've listed, with maternal fetal medicine, adult congenital, OB anesthesia, and myself. And we review every patient individually, and we go over all those aspects that I went over in my list. And we try to talk about patients earlier on in their pregnancy, so that if they do need to facilitate a move, i.e. from Wyoming, that they have ample time to do so. Sometimes we have patients who just transfer in emergently, and we make do when that happens. But the idea of the care plan is to try and plan and anticipate as many complications or barriers that they may be, so we can try and overcome those so patients are delivering in a safe environment as possible.
Question here, 1 second. Dr. Christie?
Thank you. That was an excellent talk.
Thank you.
Is there a mechanism to see these patients even before they are pregnant, right? Because this is a 30-year-old woman with hypertension. You know, this happened to her before. You know, clearly there was some opportunity for her to maybe come for a consult to say, well, hey, what are my risks for a second pregnancy? And how do I reduce those risks? So, and I know you're N of 1, but have you thought about maybe doing a pre-pregnancy screening?
Yeah, that's an excellent question. And when we talk about a lot, actually, preconception, we would love to be for that to be the norm, but it is not. It's the exception. And some of this stems from a lack of awareness, both from a patient perspective, from a provider perspective, that they think once the pregnancy is done, the risk is absolved, and it's not. And I'm hoping through sessions like this, through our collaborative care of these patients, that we can emphasize that this is a cycle, and that these patients, even if they're not contemplating a pregnancy, accidents happen, and that these patients need to be counseled about their risk of not only lifelong disease, but also for a subsequent pregnancy. For patients who are actively trying to become pregnant, we emphasize the need that they need risk assessment and modification before they embark on a pregnancy, so that they're aware of the risk they're taking on before they embark on that journey.
Dr. Grace.
So not being a clinician, is this something that the Project Echo could be as a way to sort of get this outreach beyond just the Denver metro area? As you know, I don't know if you're familiar with Project Echo or not, but it's a sort of a peer-to-peer learning that's virtual, that reaches out to physicians across the state. These sound like pretty complicated patients, so I don't know if it would fit in that type of model or not.
It sounds like you know a lot about that, so I would be more than happy to chat afterwards and see how we could incorporate that. But a lot of the interventions I listed, particularly for preeclampsia and hypertensive disorder pregnancy, when we're talking about screening, it's not a lot. We're talking about blood pressure checks, diabetes, and looking for diabetes, looking for dyslipidemia, and making sure they're exercising, not smoking, and that they're following proper diet. And a lot of that already takes place in an internal medicine clinic. It's just the population we're targeting that needs to change. So it's I think that sounds like a great opportunity that we could take advantage of.
Great. Well, thank you, everyone. Thank you, Dr. Chou. That was very informative and educational.
Thank you so
Appreciate
much.
the lecture.